The best treatment is not the most dramatic or the least burdensome. It is the least treatment that reliably solves the actual cancer problem. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Actually, hold on a second. Before we dive into all the different options, which treatment has the absolute highest cure rate? Because, as a patient, I really just want that single perfect number to guarantee the cancer is completely gone.
Well, the truth is, there's literally no single number for all skin cancers. Your outcome depends entirely on the specific diagnosis, your risk factors, prior treatments, and honestly, how we even define recurrence. You really can't compare procedures until you've completely mapped out the exact tumor. First, we have to nail down the diagnosis. Are we looking at something superficial and in situ, or is it invasive? We've got to look at the location, the size, the depth, and even your overall immune status. Plus, the functional and reconstructive consequences of a treatment, those matter immensely to your everyday life. Think about it. A small primary basal cell carcinoma on your trunk is just not the same problem as a recurrent, infiltrative one right on your nose. In melanoma, that follows a completely separate microstaging pathway. Making the right choice absolutely has to start with this baseline mapping.
So once we have that tumor mapped out, we can start looking at the surgical options. Let's dive right into Mohs micrographic surgery. What Mohs does is it removes and then maps the tissue, physically examining the peripheral and deep margins during the actual procedure. If any tumor remains, more tissue is removed, but only from that specific, mapped positive area. It's kind of like a highly targeted puzzle. This continuous margin mapping makes it uniquely useful for recurrent tumors, aggressive types of cancer, poorly defined borders, and high-stakes anatomy, places where preserving healthy tissue fundamentally changes how you reconstruct the area.
But here's the thing, Mohs is not necessary for every single skin cancer. Contrast that with standard excision. Standard excision removes the tumor with a planned clinical margin, and then the specimen is oriented and evaluated by pathology after the surgery is over. It's actually an excellent standard treatment for a lot of primary, well-defined basal and squamous cell carcinomas, and it is the standard local operation for most invasive melanomas. The big trade-off here is simply how the margin is viewed. Standard pathology uses what we call breadloaf sampling, literally checking slices of the margin rather than the continuous surface examination you get with Mohs. Now, that sampled margin is perfectly appropriate for a lower-risk tumor, but it definitely becomes consequential when the borders are unpredictable or if a major reconstructive flap is going to be needed.
Okay, but a lot of this sounds highly invasive. Can a cream just replace surgery? What if someone really wants to avoid the scalpel entirely and just go for a simpler solution?
That's a super common question. For selected superficial basal cell carcinomas or squamous cell carcinoma in situ, which basically means the cancer is sitting right on the surface, topical therapies like imiquimod or fluorouracil can absolutely be valid treatments. They treat a superficial field over days or weeks, which does require strict patient adherence, and they produce a pretty strong inflammatory reaction. However, and this is key, they do not establish a complete microscopic margin. Now, consider a procedure like curettage and electrosesiccation, where you basically scrape away the friable tumor and treat the base. That operates under a very similar limitation. It entirely lacks that oriented microscopic margin assessment. Because of that, these options are just not interchangeable substitutes for surgery when you're dealing with invasive, higher risk, or poorly defined disease.
Let's shift gears and talk about radiation therapy. This treats the tumor and the surrounding field right in place, usually over multiple visits. We typically utilize it when surgery just isn't feasible, when a patient declines surgery after an informed discussion, or sometimes as a post-operative treatment in specific high-risk cases. Modern image-guided superficial radiation actually reports high control rates in selected patients, but the absolutely critical distinction to remember here is that radiation does not provide a surgical margin specimen. You aren't checking the edges under a microscope. It is an entirely different approach to clearing the disease.
And for disease that has progressed beyond what a simple local operation can handle, that's when we step into the realm of systemic therapy and multidisciplinary care. Drug treatment is rarely needed for your routine local skin cancer. It really only becomes relevant when the disease is locally advanced, when it involves lymph nodes or distant sites, or if it carries very high-risk features. For example, systemic care for melanoma is heavily stage-driven, and it might involve immunotherapy or targeted therapy depending on the specifics of the tumor.
Okay, let's take a breath, pause, and reset here. We've laid out the tools, right? We've got Mohs, standard excision, topicals, radiation, and systemic drugs. But the big unresolved question is, how do you actually make the decision?
It really comes down to weighing the specific trade-offs. First, you absolutely must confirm the exact diagnosis and understand how those margins are going to be assessed. Second, you have to assess the treatment burden. We're talking about how many visits it takes and what kind of repair you'll need. And third, you must weigh the long-term effects alongside competing risks. You are constantly balancing margin certainty against the actual, day-to-day physical and logistical burden of the treatment itself.
Right. Speaking of long-term effects, I've seen it mentioned online that radiation doesn't require any incisions. So, does radiation literally leave no scar?
That's a huge misconception. Yes, radiation completely avoids a surgical incision, but it can absolutely cause lasting field changes. It creates a completely different pattern of tissue injury and healing over time. Patients can experience acute reactions during treatment, and then much later on, they might see changes in pigment, vascularity, texture, or experience atrophy, fibrosis, or even localized hair loss. So it really should be described as a distinct form of tissue alteration, definitely not as scar-free care.
And this brings us directly into the practical comparisons of those treatment trade-offs we just talked about. On one hand, you have margin assessment. This is the difference between complete mapping with Mohs, sampled margins with standard excision, or having absolutely no histologic margin information with topicals or radiation. Let's be clear, these are not equivalent, and you have to weigh that level of certainty against the required visits. A single surgery, even if you factor in a staged reconstructive repair, creates a very different life burden compared to weeks of applying a topical treatment or committing to a strict schedule of fractionated radiation over multiple visits.
But you also absolutely must consider the failure consequence. We just discussed surgical scars versus radiation fields and how they evolve so differently over time. But what happens if the treatment fails? Salvage after a cancer recurrence can require significantly more tissue, a much more complex reconstructive repair, or even shifting to an entirely different treatment modality altogether. The reality is, how a treatment fails is just as important as how it succeeds.
Wow, if the salvage repair for a reoccurrence is really that complex, is the smallest looking or least disruptive treatment always the best option to start with, just to minimize the immediate damage?
Actually, no. A treatment is useful only if it reliably addresses the tumor's true extent and its biology. Simpler is totally appropriate when it is oncologically sound, not merely because it looks less dramatic or happens to be more convenient. Think about it. If an invasive tumor genuinely requires a complete microscopic margin, choosing a superficial cream just because it seems easier doesn't solve the actual cancer problem. In fact, it actively heightens the risk of landing in that exact complex salvage scenario we were just looking at.
So the absolute crucial point to take away from all this evidence is that there is no single best treatment for every skin cancer. It just doesn't exist. The strongest clinical choice happens when you perfectly match the specific treatment modality to the exact diagnosis, the anatomical risk, the patient's health status, and their legitimate, everyday priorities. You have to balance the need for margin confirmation against the burden of the treatment itself, the reconstructive impact, and the long-term follow-up that's going to be required. Things like cure, function, appearance, and your personal tolerance for uncertainty, they all play a completely valid role within medically sound options.
Navigating all these competing priorities can definitely be challenging. A totally practical next step is simply to get a second opinion. This is particularly useful when you're dealing with a rare diagnosis, when treatment recommendations differ between providers, or when the proposed therapies carry vastly different long-term trade-offs for your specific lifestyle and health. Dr. Hocker created SkinTrust to provide free evidence-based dermatology education and help patients and clinicians make clear decisions together. We highly encourage you to read the complete SkinTrust article on skin cancer treatment options to review the full evidence and to bring this concise explainer into your conversation with your treating clinician to plan the approach that is truly right for you. Ultimately, the best treatment isn't just about fighting the cancer, it's about protecting your quality of life. So when you look at all the options, which trade-off are you most willing to make?